Dr. Domanko's talk title is Rural Medical Education, the Hope for Recruitment and Retention. Dr. Domanko graduated with his MD from the University of Saskatchewan in 1968 and completed a preceptorship in anesthesia at the University of Minnesota in Minneapolis. He did a rotating internship at Ottawa Civic over the next year, and he served as a chief of anesthesia for 32 years at Winchester Memorial Hospital, also practicing obstetrics for 30 years during that time. He served as a CME coordinator at St. Lawrence Medical Clinic in 1997, and in 2005 as the Director of Medical Education, Winchester District Memorial Hospital. Since 2005, he has been a lecturer for the faculty of Medicine, University of Ottawa, and a community preceptor for undergraduate medical students and family medicine residents, and the postgraduate family medicine residency program on-site coordinator for the University of Ottawa. He's an examiner for the MC2 family medicine, and in 2013 became a designated chief examiner for the Ottawa site for the MCC2 Medical Council of Canada. In 2010, Dr. Domanko was recognized with the Glenn Sawyer Award for significant service to the OMA, medical profession and community, and the Helen Keller Fellowship Award through the Lions International for Community Service. I'd like to welcome Dr. Domanko.
Thank you very much. It's a pleasure to be here, and it's a pleasure really to see some of my classmates, rowdy as they are. After being away for some 45 years, it's a pleasure to reacquaint. Now, I have no conflict to declare, and the object of this presentation is to discuss the difficulty in recruiting and retention of family physicians. We will touch on some of the factors influencing this problem, offer some solutions, and briefly touch on some of the experience in our small community hospital at Winchester, Ontario. So, a little bit of background. In 2010, there were just under 70,000 physicians, active physicians in Canada, and this was an increase of 2.3% over the previous year. And we had 203 physicians per 100,000 population. Overall, the population in the last 30 years, physician to population, grew from 150 per 100,000 people to 203 in 2010. And the faculties of medicine across Canada were very busy. They awarded a record number of medical degrees. In 2010, 2,448, an increase of 30% from 2005, and a whopping 55.1% since 2000. And on top of this, we have approximately 4,000 Canadian medical students studying abroad. So things look pretty rosy, right? Also, the demographics are changing. We have more and more female practitioners. 1990, only 12.4% of physicians were women, and by 2010, this increased to 36.1%, and that is growing. So things should be great, and yet there remains a shortage of family physicians in rural areas. You can see from 2005, so from 1998 to 2005, the population ratio did not change very much. Each rural family doctor looked after 1,340 patients, 2008, and virtually not much change 7 years later. If we look at this provincially, you can see that there's still not a whole lot of difference. So we look at two provinces, say Saskatchewan. Saskatchewan did a little better. They had 1,833 patients per rural GP, down to 1,485 in 7 years. My province of Ontario really didn't change very much, about 1,500 patients for each rural GP. And you can see there's a huge difference patient population with urban physicians, 683 in Saskatchewan. Ontario, a little bit busier, urban patient population is about 1,000. And I know that rural GPs now in Ontario have approximately 1,500 patients. Our group, we average about 2,000 patients per physician. So this is a little hospital south of Ottawa. It's Winchester District Memorial Hospital. I'll refer to it as WDMH. It's a lot easier to say. And we have developed a bit of a program to try to recruit people that are interested in rural medicine, try to mentor them, try to teach them. We have the hospital is 30 minutes away from Ottawa, so it's hardly remotely rural. We are 30 minutes away from tertiary care facilities. We have a close academic tie with the University of Ottawa Medical School. We have an Office of Academic Affairs run by a lady that served under 4 deans of medical school in Ottawa. So we have close ties, and we have developed a program with dedicated, really interested mentors who want to take on students and residents. We have, I work with a group of 10 people further south from this hospital, all of whom have different interests, and again, they're keen about dealing with residents and students. And I really enjoyed the talk on mentorship because the young people expressed the positive aspects of dealing with students and residents, because it really does help. It's stimulating. It encourages you to be better. It allows you to give something back to the medical community, and I think it's very, very worthwhile. So this is our little hospital. It's new, built in 2009. It's in a rural area, a lot of dairy farming. And it was amazing because this hospital, I think, cost something like $60 million, and $18 million was raised by the community. It's a highly, highly valued and supported hospital raised by, or contributed to tremendously by rural people. And that money was raised in approximately 2 years. It's got 64 beds. We have some very good programs. I'll run through this with you. It's busy. We have about 23,000 emergency visits. We have approximately 5,000 surgical cases a year. And the STAR program is the births. This is last year. We delivered 646 babies. We're up to 700, predicted 700 this year, and we are getting busier and busier. The aspect of having 24-hour epidural service has attracted a lot of people. We have 8 large birthing rooms, and we're getting people from distant areas, cities like Cornwall, Brockville, coming to this little hospital where they can get very good care. And we're very proud of this because last year it was the most highly recommended maternity program in Ontario based on patient satisfaction. It scored 100%, and no other hospital in Ontario, large or small, came close. So, we've signed formal agreements since 2006 with the University of Ottawa, and we've been teaching for a long time, since the 1960s, late 60s. And having a formal agreement always allows data to be captured, allows evaluations, helps us to improve, and helps us to be recognized. And we have since expanded, and we have now affiliation with about 13 universities and colleges in this little hospital for a variety of disciplines. You can see that we're busy. In 2008 and 9, we had 1,708 teaching days, and in the last year, that went up to 2,384 teaching days. We have to submit this to the province. Now, that's a little bit about our hospital, my own personal experience. But the issue with retention and recruitment is difficult all over. And this is an article from the Canadian Journal of Rural Medicine, and it was done by Marco Visconti, who is from Queensland, Australia. And he compared Canada and Australia with the same issues, basically, a large land mass with a very small population. And he thought that the analysis of this issue should include stages of a physician's experience. So stage 1 is life before medical school. Stage 2, experience during medical school. Stage 3, experience during post-grad training. Stage 4, recruitment and retention after completion of fellowship qualifications. And stage 5, a maintenance action plan. So let's talk about stage 1, life before medical school. In Canada, it's estimated that 30% of the population is rural. Now, this is sometimes difficult because there's no concrete definition of rurality. Some people say less than 10,000, and some studies say less than 25,000. And only 6% of all medical students come from rural areas. That figure shocked me. And in Ontario, more than 50%, bordering on closer to 60% of the people come from, guess where? Toronto, center of the universe. Yeah, right. And research indicates that a rural medical graduate is more likely to work in a rural or remote area, and I think that's well known. So, another study done by Olga Safran from Alberta wanted to see if perceived preparedness for family practice, she wondered whether a rural background helped this. So the hypothesis was that a rural background and ability to adjust to rural practice are strong predictors of recruitment and retention of rural physicians. And this study examined the association of family medicine graduates' rural and urban background and their self-reported preparedness for practice. And here the rural was classed as less than 10,000 population. And this was a retrospective survey of family medicine residents from the University of Alberta and Calgary from 2001-2005, and they used the Likert scale where you measure intensity of your responses. So she analyzed 18 elements of critical family practice, and you can see some of the examples there, and 8 interdisciplinary issues, 10 practice management issues, and 8 non-clinical aspects of family medicine. And there was not really much significant difference in preparedness, urban versus rural graduates in the majority of these elements, except for 3. And these were time demands of rural practice. Rural people were much more prepared to accept that, 95% versus 79.3% of the urban people. Understanding rural culture, 92.5% versus 70.2%. And ability to understand small community living, 92.5% versus 72%. So her study suggests that rural exposure facilitates understanding of rural culture, which makes sense, and increased exposure of urban residents to cultural aspects of rural practice may improve recruitment and retention of family physicians. Let's move on to stage 2, demographics. It was noted previously that the length of time spent living in a rural area is a strong corollary for retention. And also, if you are older, a male, and in a relationship with someone interested in living or previously living in a rural area. I happen to marry a farm girl. That's why I'm in rural practice. And the elective experience is also important. It is important to place students in rural areas where practice and practitioners are closely linked with academic program activities. There are positive and negative predictors of graduate practicing in rural areas. The positive ones are basically completing something, some rotation in a rural area, and it judged to be a positive experience, that you, if you came from a rural background, this would be even more positive. And you have to choose the right elective. I mean, you don't want to do neurosurgery in, Carlisle. Right, Don McRae? Okay. Okay. And you want to choose good role models. And you want to try to gain an understanding of the needs of people living in rural areas. The negative ones are what you can expect anywhere. You want to have collegial support. If there's a lack of it, that's bad. You want to be able to take vacations or have coverage. You want medical education. You want good on-call arrangements. And sometimes the misconception that rural practitioners are less qualified than urban specialists. This annoys me, this attitude sometimes, that people think that we're banished to the country because we can't handle urban practice, or that we didn't want to be specialists or couldn't be specialists and ended up being just a GP. You also have to have a partner who wants to live in a rural area, and you want to have good facilities for accommodation, good recreational facilities, and so on. Career aspirations play a role. Studies show that students are more likely to practice in rural areas if they wish to become a generalist, if they've had ample positive rural experience. And in Australia, they have something called a bonded scholarship agreement. That is, if you swear that you will go to a rural area for 5 or 6 years, it may enhance your ability to get into medical school. And this seems to work very well. They've done studies that indicate that after 5 years, there's a great deal of retention in rural areas and isolated areas. And if you come from a community where practitioners were highly respected and active in community, this might influence your ability to practice and stay in a rural area. Conversely, you are less likely to go to a rural area if you wanted to specialize and if you had financial support by your parents. I don't know why. Maybe you don't want to get too far away from them. Community-based education, and this is really important. It's a curriculum based on the regional and recognition of health needs of the surrounding community. I just listed 3 examples. The Northern Ontario Medical School usually takes people from Northern Ontario because they understand the northern culture. University of Saskatchewan is well known because of their recognition and inclusion of the First Nations communities. And the University of Ottawa is expanding out and developing horizontal programs for residents with dedicated, motivated preceptors while remaining linked to academic activities provided by the medical school. Stage 3, experience during postgraduate training. This is different in Australia and in Canada. In Australia, you must complete 1 year of internship as a generalist. Anybody here remember rotating internships? Followed by a 2nd year as a family doctor before you can apply for specialty training. We talked about the bonded program with a high retention rate, and there is a substantial remuneration paid in Australia for a rural generalist training pathway. In Canada, family medicine training involves mandatory 2 months of rural service, and there is no rural generalist training program in Canada. So, there are some things that I think the colleges must look at. The program director should try to ensure positive rural medical training by seeking dedicated, motivated preceptors. Social isolation must be avoided. There should be suitable housing. Employment for partner is vital. We lose many, many people who don't want to come to rural areas if their partner has no ability to work or to practice his or her profession. And there should be access to quality education and recreation. Stage 4, recruitment and retention after completion a fellowship qualification. So there are positive and negative issues here associated with the recruitment of doctors in rural practice. So I think we've gone over most of these. You can see that positive, obviously positive experience, and adequate collegial support, good remuneration, etc. And the negatives, of course, what we all sometimes worry about, experiencing burnout in rural practice, inability of the partner to find employment, difficulty in achieving a balance. And this sometimes is really interesting because difficulty achieving a balance between your professional and personal relationship with the people in your community. And I know that in Ontario, they made some concessions as far as people going up north and so on. Single people, for example, that they are now allowed to perhaps date or have some social contact with some of the patients, as long as it's done reasonably well and not taking advantage of your professional status. They made some concessions in that regard. So, and basically, collegial support is really, really important. Now, Dr. Rourke, we all know him from his pediatric forums, and he is at St. John's Memorial. And he, in 2003, published an article in the Canadian Family Physician. He offered a set of recommendations that were based on practice response provided in a cross-sectional survey. And this was his idea about recruiting and retaining physicians. So he thought he'd start with medical education. And he wanted to have trained rural clinical teachers and have some degree of undergraduate return of service agreements, and increased mandatory and elective postgraduate training options, advanced skills training, and access to continuing medical education. And then in practice, basically, he wanted to be sure that family doctors could access friendly specialist care. I don't know how you can assure that. Some specialists are friendly when you call them, some are not. And I don't think that's ever going to change. Okay? Improvement in technology, and so on. Access to other professionals, and increased remuneration, and improved shift arrangements. So the maintenance action plan, stage 5, the literature suggests doctors who choose to remain in rural practice were really more satisfied in their practice than their urban colleagues, despite being busier and having more patients. The positive aspects were they had an increased breadth of clinical presentations, increased demand for procedural work. And this is really important when you're dealing with students and residents. They love to do things. They love to do a thoracentesis, paracentesis, put in an IUD, do lumps and bumps, inject joints. And if you can involve them in doing that kind of stuff, they really, really get keen, and they like to do some of the added things that perhaps urban physicians don't have the opportunity to do. And it also, you're working in a cohesive and supportive learning environment within the rural practice. You know these people, the staff knows these people, and there's a great deal of satisfaction sometimes when you're able to do that. And there's an increased clinical and managerial autonomy. Sometimes that's advantage, sometimes it's not. And appropriate remuneration. We are doing a little bit better, certainly as family doctors in Ontario. So the negative one, lack of appreciation for services provided, poor relationships with hospital administration, etc., suboptimal remuneration, long working hours, poor on-call arrangements, inability to find coverage. These are issues that are found elsewhere, not only in rural medicine. So, summary of the key factors. You are more likely to practice in rural areas if your formative years were spent in rural areas. It's important for medical schools to introduce socially accountable medical education and a curriculum that recognizes the health needs of an aging rural community combined with positive clinical placement with motivated preceptors correlate well with rural recruitment and retention, and financial incentives, housing, spousal employment, childcare, educational, and recreational facilities are important. And that they now suggest that longitudinal efforts should be directed at various points, even starting at high school. So maybe the deans of medicine should go to small communities, start talking to students in grade 9, 10, 11, and so on, to indicate that living in a rural area, serving the rural community, is indeed a pretty good calling. So our little hospital has instituted this program for a little while. How do we do? Well, we're pretty proud. We did pretty well. Over the last 6 years, we have recruited 6 family physicians, 5 of whom had completed undergraduate and postgraduate rotations at Winchester District Memorial. And we've recruited 7 emergency physicians, all of whom completed undergraduate and postgraduate rotations at Winchester. And when we recruit students, we tend to get more specialists, and the place is doing very well. And I thank you for your attention.
Thank you very much. It's amazing what you can do when you build relationships. Are there any questions for Dr. Domanko?
Yeah, Wayne. How do the students and the residents, how do they decide to pick to go to Winchester? What's the process?
Well, I don't know. It's a good question. It sounds like I'm bragging, but perhaps I am. We have a good reputation. I think the fact that it is close to Ottawa, close to the academic center, the fact that there are facilities provided, we have guest homes that they can live in, during the rotations, and it gets a lot of it's word by mouth. In fact, we cannot accommodate the numbers that we have that ask for surgical rotations, whatever rotation, obstetrical rotations. Just to give you an example, we have had, we take 2 residents a year. My group of 10 has 3 of these residents. I have Amy, who comes from University of Calgary. She's starting her 2nd year with me, and we have 3 others that come from other universities. When I do the CARMS interviews, in the last 4 years, we take 2 per year, remember? We've had the lowest number of applicants were 70 for the 2 positions, and the highest was 96. And we get to take 2. So I don't know, it's perhaps the program's inclusive.
And they submit their names to the university.
Yes, right.
To be
right.
chosen.
Yes.
How many other community hospitals around the area are doing the same thing? Do you have any idea?
I don't think many are. I don't think many are. I know that Cornwall, it's a city of about 50,000, takes the occasional medical student, but they don't have a residency program in family practice. Brockville's probably size of Yorkton, I would say. And again, they have a larger hospital, but they don't. They will take students for rotations, but they don't have a residency program. So not many.
Yeah, thanks, Wayne. I just retired from a tertiary referral center in the upper Midwest in USA, and thanks to the magic of the internet, I was able to read our local newspaper every day, and this morning there's a huge article on the same thing, retention and recruitment and retention of family physicians for rural areas. And it's a problem that's not unique to medicine. I mean, lawyers, veterinarians, dentists, nurses, nobody seems to want to go to rural areas anymore. And I guess my question is there anything where all the different groups of professions could work together and kind of kind of do anything like that as a united front?
It's a good question, Bob, and I know that more brilliant minds than mine have looked at this, and I don't know that there's an easy answer. I know that certainly in Ontario they're making some effort, financial efforts, and some communities. We have something called a Rural Index Fund, a REO rating in Ontario, where you're rated as far as rurality goes by the number of unattached patients, your closest tertiary care center, how close you are to an airport, many factors. And if you have a rurality of greater than 40, the higher the number, the more rural you are. They will sometimes give you an incentive of $10,000 a year for 4 years. And what some communities are doing, in fact, our community did that, the local municipality will match that. And so you can get a new graduate that's going to start out with $80,000 over 4 years. And that sometimes helps to recruit them. And then if they get interested in living in smaller communities, often they'll stay.
Mm-hmm. One other quick question. I've been away from Canada too long, but up here, do you use like physician extenders, like nurse practitioners,
Yes.
PA, nurse anesthesia?
Yes,
Okay.
Yes, we do. And in fact, when I said we're affiliated with 13 colleges, we've had PAs in our hospital. One of my colleagues has trained PAs for 6 months at a time. And we have nurse practitioners as well. And some hospitals are using nurse practitioners as hospitalists. You know, I know in Cornwall they have 2 that are doing hospitalist work.
Mm-hmm.
I very much enjoyed your talk and the
Thank
idea
you.
about recruitment. I look at it a little bit different. I'm a subspecialist in surgery. And if I remember the figures correctly, and Dr. Shaw may be able to help me, but I understand at the present time in Saskatchewan, 53% of our physicians are trained from elsewhere. And the last time I heard, not that long ago, is my understanding is our retention of our medical students, whether you're a specialist or not, was less than 50%, are leaving the province once they graduate. And with our last speakers as well, and what we were discussing last night, I look at something a little differently. For example, we now get second-year general surgery residents doing I'm a vascular surgeon. I'm teaching them how to tie knots. A second-year resident in general surgery. And we were commenting, one of our colleagues at the present time is a forensic psychiatrist, and he did more appendectomies as a rotating intern than any first or second year resident does in general surgery. And so your comment about the bonding program from Australia, the loss of the general rotating internship, or how it could be incorporated in a different way, to me may be the answer to a few of our problems. And to access the rural, I constantly tell our medical students, because they now have to make a decision in second year of what they're planning to do for the rest of their life when the match rolls by in third year. And if you're not shadowing, I constantly tell them, you should be going to the rural communities, because that's where you're going to do exactly what you listed. And to me, it comes back to that one denominator about that rotating internship and what it meant. And I know, as we heard yesterday, we have 4 generations of different people and their experiences, but just pops in there again.
I couldn't agree with you more. I think we're really lacking something, and it's very difficult for people to decide what they want to do in the second year of medical school. How do they decide they're going to be a plastic surgeon? Or how do they decide they're going to be a neurosurgeon? I don't know how you can decide that without having some experience. And it's amazing. I know that when I do some of the CARMS interviews, what several students tell me is that when they do go to a rural rotation, they're overwhelmed. You know, they go visit some older doctor like my classmates, not me. And these people can do a lot of things, and this impresses them. This impresses them, and they want to do this, but yet there's a fear. There's a fear of not being able to do it, and it's perhaps a little bit more daunting and demanding that they can handle. And I don't know, I think that if you are subjected to a rotating internship, I think you get more exposure, and I think you're much more prepared to handle that type of thing. One of the questions when we do the interviews at University of Ottawa for family practice residents is what is your greatest fear? And usually the answer is inability to keep up with everything and to serve my patients well. And that, I think, overwhelms them sometimes to going into a rural area, and I think they'd be served much better if they did have that rotating internship. Thank you.
Well, thank you very much, Dr. Domanko. That was a really interesting presentation, and you probably will need to mentor us. We have a lot of pieces in the mix, but I don't know whether we've developed the relationships like you have. So thank you very much.
Thank you. My pleasure.
Small